Okay, so welcome everyone. Thank you for taking the time out of your day to join us today for what promises to be a fantastic webinar, which we've called Research Power Hour, Unpacking the STRIDE Trial. My name is Chris Marr. I'm a professor in the School of Public Health at the University of Sydney. I'm also the director of the Institute for Musculoskeletal Health at Sydney Local Health District. Before we start, I'd like to acknowledge the traditional custodians of the land upon which the Institute stands, the Gadigal people of the Eora Nation. I would like to pay my respect to their elders past, present and emerging. The Institute for Musculoskeletal Health has a strong program of research looking at how we can use physical activity and exercise to improve people's well-being and function. And of course, the STRIDE trial is a perfect example of that style of research. And so I'm really pleased today that the Institute can host Dr. Nancy Latham, who is the STRIDE study director. But we also have some outstanding directors here in Australia and at the Institute. And I wanted to applaud and acknowledge the work of a few people. So in particular, Professor Kathy Sherrington, Professor Anne Tiedemann, and also Dr. Leanne Hassett, who've done incredible work promoting physical activity, well-being and function in older people and people with disability. But of course, as most of you know, I've got absolutely no expertise in this area. So what I'd like to do is to pass to someone who does, and that's Associate Professor Anne Tiedemann. So Anne is an Associate Professor in the School of Public Health. She also holds a prestigious Robinson Fellowship. So please welcome Anne, who will be our chair this morning for what promises to be a fantastic webinar. Thank you, Anne.
Thanks, Chris, and welcome everyone to the webinar. It's great to see so many people joining us from all over Australia, and we've actually got some international audience members as well. So the format for the next hour will include a presentation from our international guest, and then our three expert panelists will comment and ask questions of the guest, and then we'll have questions from the audience. So audience, please ask your questions through the Q&A function, and we'll be monitoring that, and I will be reading them out later. And the webinar will be recorded. So let's get started. It's my great pleasure to introduce our guest presenter, Dr. Nancy Latham. Dr. Latham is the study director for the STRIDE trial at Brigham and Women's Hospital and a lecturer at the Harvard Medical School, both in Boston, Massachusetts. She has extensive experience in the conduct of research investigating exercise and technological interventions to improve function and reduce falls in older adults. And Dr. Latham has a background in physical therapy, and she completed her PhD in clinical epidemiology at the University of Auckland in New Zealand. So welcome, Dr. Latham, and we look forward to hearing about the STRIDE trial.
Thank you. Well, it is such a pleasure to be sharing the findings of the STRIDE injury prevention trial with you. I think we recognize how much Australia leads a great deal of fall prevention and musculoskeletal and injury prevention work. So I'm just really delighted to be able to share these results, and I'm looking forward to discussing the findings with everyone on this panel. Oops. There, sorry about that. So any study like this, of course, is an extremely large team effort, and it's really an honor that I'm presenting this work on behalf of my colleagues. I want to acknowledge that this was a multi-PI trial, and the three PIs were Shelley Basheen from Brigham and Women's Hospital, Tom Gill from Yale University, and Dave Rubin from UCLA. Our director of the Data Coordinating Center was Peter Peduzzi from Yale. I was the study director. We of course acknowledge our funders, the PCORI, the Patient-Centered Outcome Research Institute, and the National Institute on Aging. The findings were published, the primary findings were published at the beginning of July in the New England Journal of Medicine, and that reference is here. I'll also be showing that reference and links to other components of the study at the very end if people are interested. But in that study, you will also see the many co-authors and other people acknowledged who were essential to getting this study done. So I think anyone who has taken the time to Zoom in this morning is probably well aware that falls are a common and serious problem for older people. The estimates vary slightly, but approximately 1 in 4 older Americans, it is estimated, will fall each year, and about 20 to 30% of those people who fall will have moderate to severe injuries. Falls are a costly problem with a high health burden. To take some US data, fall injuries lead to approximately 2.8 million ED visits and 800,000 hospital stays annually in the US. The good news is that we have now decades of excellent research, excellent efficacy studies, and rigorous meta-analyses have found that falls can be prevented. One of the most promising type of interventions for community dwelling older people is multifactorial assessment and management. By this I mean when older people who are at risk of falls have their risk factors assessed and a plan to address and manage those problems, reduce those risk factors, is put into place. The Cochrane Review from 2018 found that there had been 19 trials that had investigated this and found approximately a 23% reduction in falls. There were no significant differences, though, that were found in falls resulting in fracture, hospitalization, or medical care, but there was fairly low power to detect these effects. So what did we not know, though? What was our rationale for leading to the STRIDE trial? Well, one of the main questions was, we had this evidence of efficacy in research trials, but could we translate these fall prevention strategies effectively into real-world primary care? We know that when we take things out of more carefully delivered research studies, where we might be more selective about the patients who are included, and we might ensure that people are much more likely to receive every intervention, that the effect might be different. And in STRIDE, we did work to use the existing resources within the primary care practices that we worked in, the existing health and community resources. So there were many barriers potentially to people actually taking the steps to adopt the changes to reduce the risk factors. We also, the main driver of STRIDE was to know, could this multifactorial risk reduction approach be effective in reducing serious fall-related injuries? Although we have evidence now from those many trials that it seems to reduce falls, STRIDE was designed to answer this question of, could this approach in a pragmatic trial in primary care reduce serious fall-related injuries? So to conduct this, we conducted a pragmatic multi-site cluster randomized trial. It took place in 86 primary care practices across 10 diverse healthcare systems across the US, and they were randomized half of the practices to intervention and half to enhance usual care. We used a central IRB to provide human subjects approval. Patients provided oral informed consent, so strictly by telephone, or if the people had cognitive impairment, assent with a proxy respondent. If the person did not have a proxy, if the person had a proxy respondent, we did not have any limitation for cognitive impairment. A key part of the design and implementation of this study was that we had input throughout it from older people, patients, their families, and other people with expertise in aging into designing all parts of the study, including the intervention. And this is just a map showing the 10 healthcare systems that it took place in. We tried to have geographical representation from around the US, and also to have healthcare systems that had a range of practices that were located in rural, suburban, and very urban practices as well. Our participants were older people who were patients in the 86 participating primary care practices. They were community living people who were age 70 and above, and they had to be considered to be at risk for fall-related injuries by answering yes to one or more of the screening questions that you see here, indicating that they either had had a fall-related injury in the prior year, 2 or more falls in a prior year, or were afraid of falling because of a problem with balance or walking. They had to be fluent in English or Spanish, adequate to provide consent in those languages. And again, they were excluded if they could not provide consent because they had an impairment on the Callahan cognitive screen, and if there was no proxy person who could provide consent for them. For the people who had screened positive as having one or more of those 3 fall risk factors, recruitment packets were mailed to them. People were given 2 weeks to send back an opt-out postcard if they did not want to participate. Otherwise, they received a telephone call to obtain their consent and complete the cognitive screen and complete the baseline assessment for people who consented and passed the screen. In total, 5,451 people were enrolled in the trial. Our follow-up took place with telephone interviews every 4 months for 44 months by blinded assessors. During these telephone calls, people were asked about their falls and fall injuries, with the recall was facilitated by monthly calendars that they had been sent. They were also asked about hospitalizations, ED visits, and other healthcare utilization. The median follow-up was 3.2 years. 8.1% of our participants died during the trial, and 600 or 11% withdrew consent over the average of 3.2 years of the study. There were no differences in these between treatment groups. So our intervention, the heart really of our intervention, was a nurse falls care manager who worked with the patients within the primary care practice. Their role was to conduct a risk assessment of fall risk factors using standard assessments that were developed and taught, and using evidence-based algorithms that were developed based on the best evidence that we could find for the 7 risk factors that we were focused on. And that was used to guide the treatment plan. The FCM, as we called them, the nurse, would work with the patient to develop their own fall injury prevention plan. They would co-manage this with the primary care doctor, obtain approval for it, and they would work to engage the patient in self-management and use motivational strategies to help encourage behavior change. The nurse directly implemented some recommendations, other ones were communicated to the primary care doctor, and they support and monitor the patient's progress and revise the plan as necessary for up to 40 months of the follow-up. The 7 risk factors that we focused on, you can see here, strength, gait, and balance disorders, osteoporosis, visual impairment, feet and footwear problems, medication risk, home safety risk, and postural hypotension. People in the control group received, in fact, enhanced usual care. They were, all of the patients who were in this group were given a pamphlet and told that they had been identified with risk factors that put them at risk of falls. The pamphlet provided some basic information from the CDC about steps to prevent falls, and the patients were encouraged to discuss fall prevention with their primary care doctor. The physicians in the enhanced usual care group were also offered an educational webinar about fall prevention based on the CDC study program. Our outcome measure, so our primary outcome was the time to the first adjudicated serious fall injury. And you can see our definition of the serious fall-related injury here. It was basically a fall that was serious enough that it warranted medical attention for the fall and had these associated conditions, or hospitalization for a fall that resulted in head injury, sprain or strain, bruising or swelling, or other serious injury. Our secondary fall outcome was the time to the first self-reported fall injury. So this was any injury that the patients reported when they called in, and we did not try to determine that that was actually fell into that fairly specific definition of a serious fall-related injury. So it could be non-serious or serious. For our primary outcome of the serious fall-related injuries, we had a very comprehensive process set up to confirm when the patient self-reported that they had had this fall. In order to be considered an event, it had to be confirmed through data that was obtained from the clinical sites, from their electronic health records, from their medical notes, and we also had really great cooperation from our Medicare, from CMS, which provides care to older adults in the US, who also provided data to us to help provide an indicator if an injury had occurred. So we had 2 blinded physician adjudicators who would independently look at one of the primary outcome events, what we consider to be, and events that were definitely or highly likely to be a serious fall injury by both adjudicators were considered to be true serious fall-related injury events. If they were unresolved, it was brought to an outcomes committee monthly for a final decision. Our analyses were multi-state survival models incorporating clustering and a semi-competing risk of death. We adjusted for randomization of practices by healthcare system and included the covariates you can see here that were also used for the constrained randomization. Patients who were lost to follow-up without a prior serious fall injury were censored at their last interview. The effect of the intervention relative to the control estimate was estimated as a hazard ratio with a corresponding 95% confidence interval for the primary outcome, and we used 99% confidence interval for the secondary outcome. Oops. There. So just briefly, the demographic characteristics. I think the most important thing to take away is that for all our demographic and clinical characteristics, there were no differences. They were extremely well balanced between the intervention and control group, which I guess is what happens when you have a study this large. And the population was typical of what I think you would expect for a fall injury prevention trial. The mean age was close to 80, about just slightly over 60% of the people were female. So that was the population we enrolled. For considering the intervention fidelity, we found, if you look at each column here, looking at the first one, we've listed, and in the very first column is all of the risk factors which we sought to address. Then the second column is looking at the risk factors that were assessed. And you can see that for people who had had almost 100% of the people had all of the risk factors assessed during their interactions with the fall care manager. If you move to the next column, as expected, when they assessed those risk factors, there was a range in people who actually had the problem. So it ranged from impairment of strength, gait, and balance, which 100% of people had some sort of impairment, which I think is expected from who we were targeting, people at risk of falls. Whereas, for example, postural hypotension, only about 20% of people actually had that risk factor. And then as we move over, we then look that there was also variation in the risk factors that people prioritize with the fall care manager and that they agreed to address. So again, the strength, gait, and balance, which was addressed through exercise or physical therapy overwhelmingly, almost all people who had that risk factor addressed that, whereas other risk factors, and I think the one that stands out is the first row, the use of certain medications that we know increase the risk of fall, there was much lower uptake of people being willing to address that risk factor. So here we're looking at the plot looking at our primary outcome and the results. So again, our primary outcome was the first adjudicated serious fall injury. And we did not find a significant difference between the control and intervention group, as I think that makes it sort of clear when you look at those lines. Hazard ratio was 0.92 with a 95% confidence interval ranging from 0.8 to 1.06. When we looked, we had a number of pre-specified subgroup analyses of the primary outcome. And again, the biggest takeaway is that none of the subgroups were found to have a significant effect either. In the intervention versus the control group. You could see that there were some groups where the intervention seemed to have a stronger effect in them, particularly if you look at people 80 and above, so the older people, the people, interestingly, who enrolled who only had fear of falling as their only screening criteria, seem to have more benefit, and women maybe just slightly more than men, but again, these were not statistically significant differences. If we look at the type of serious fall-related injury, again, we did not find a significant difference between the intervention and control for these. But I think it is just interesting to note that if we look at the fractures in the intervention group, that's the first column versus the control, there were fewer fractures in the intervention versus the control, 6.9 to 7.7%. And things like overnight hospitalization, again, was lower in the intervention to the control, not statistically significant. If we look at our secondary outcome, which was, again, the first patient-reported injury from a fall. So this could be either a serious or a non-serious injury, any type of injury. Here, we did find a significant treatment effect. The hazard ratio was 0.9, so actually a fairly similar hazard ratio to what we found for the primary outcome, just slightly lower, but the confidence interval was narrower. Our 99% confidence interval was 0.83 to 0.99. So the summary of the key findings was that the effect on the primary outcome, the first adjudicated serious fall injuries, was less than expected when we went into the trial. We had hoped it had been powered for a 20% reduction, and we achieved an 8%. The effect size at 8 to 10%, it was consistent across the outcomes and subgroups, and also in the many different models that we ran. It was around 8, 8 to 10, some of the models were 12, but it was essentially around an 8 to 10%, very consistent across the different outcomes that we looked at. And it was not statistically significant for the primary outcome, but was for the secondary outcome. Why was the effect size smaller than expected? Well, I think we'll probably be talking about this here, but some thoughts that we have had was that part of it could be adherence to actually maintaining these interventions in a pragmatic trial. Again, the fall care managers made recommendations about exercise, and we worked very hard to identify community-based exercise programs, to let them know about physical therapists in the communities and things. But unlike other studies, if we're just focusing on the exercise, the patients would have to get themselves to those programs, sign up and adhere to them. There was not somebody coming to them. And that was true for all of the interventions that we would make referrals within the healthcare system for their vision or other barriers. But there are real cost barriers, especially in the American healthcare system, also transportation barriers to that. Also as a pragmatic trial, the adherence to things like the exercise program was not monitored in the same way, because we wanted to make it close to clinical practice where people would not be given things that could change their adherence, but that could change the effect. Also, participants and their physicians might have chosen less effective approaches to risk factors and or selected some risk factors over others, maybe didn't choose to focus on some of the ones that they were more reluctant to want to change, because we knew if people had all 7, they wouldn't try to change all at once. And maybe some of the more potent interventions were not the ones that we're focused on. So I think I was going to cut off there because I think what will be even more interesting is to hear other people's thoughts and questions about this at this time. So thank you for giving the chance to share.
Thanks very much, Nancy. What an interesting presentation and what a huge amount of work that trial was. So well done.
Thank you.
I'd now like to invite each of our panellists to give a brief reflection and ask a question or two of Nancy. So we'll start with Professor Sherrington. So just to introduce her, Professor Kathy Sherrington is an NHMRC Senior Research Fellow at the School of Public Health at the University of Sydney. Kathy leads the Physical Activity, Ageing and Disability Research stream within the Institute for Musculoskeletal Health and is also the Deputy Director of the Institute. Prior to completing her PhD, Kathy worked clinically as a physiotherapist in rehabilitation and aged care. So Kathy, do you have any questions or a reflection on the presentation?
Thank you, Anne. And thank you so much, Nancy, for that such a clear, excellent presentation. And also congratulations on what a massive effort actually achieving that trial and being published in the New England Journal. I think it's absolutely fantastic for the issues of, falls and fall-related injuries to, get that type of prominence. So yes, well done.
Thank you.
My question's probably predictable about the exercise adherence because, as you've identified, other studies where exercise programs have been delivered have found larger effects. So in our Cochrane review of exercise for falls prevention, which excitingly is actually was the most downloaded Cochrane review of those published in 2019. So that was fantastic in terms of the interest in the area. And so that found, around a sort of 20 to 30% reduction in falls and actually a similar size effect on fractures. Similarly, the Otago program, so they did a meta-analysis of fall-related injuries from their interventions and actually found a similar effect size on fall-related injuries as on falls. So I guess, my question really, and I fully understand, why you were not able to, really monitor adherence in a trial this size. But I guess just to ask your reflections on that issue of, did the people actually do much of the exercise intervention that was suggested? And I guess how did the nurses actually go about kind of targeting those exercise interventions to the person's kind of physical functioning? And so I guess they're my questions. Love to hear your reflections.
Okay, great. Well, maybe I'll start with the second one first, if that's okay, how they targeted the exercises. So again, for all of the interventions, we had a team of people who tried to look at the literature and we came up with algorithms to try to guide the nurses through where they would recommend directing people for the exercise program. And so, and it was really steering people towards either community or home-based programs for the people who were at risk of falls. That's why they were there, but did not have other impairments or mobility problems, or should they be going to an outpatient physiotherapist if they were more mobile, or should they be getting a home health physiotherapist coming into their home, and so guiding that. And so that's something that we're now still continuing to look back and reflect on that as we move forward, how we might improve how we triage even at that step. I'm not able to we just don't have the data to definitively say how much activity the people did. We did hear from the nurses that many people were reporting back that they were engaging in activity, but this was a long duration of a trial. We all know it's hard to sustain exercise and continue that. We very quickly realized that there were a lot of great community-based resources. The practices had to be located in places that had evidence-based community fall prevention programs, which are quite well supported here. But we quickly realized that we developed and built some more resources to support the people who wanted home-based, in addition to, say, PT or instead of. And so we were quickly trying to develop materials to mail out that the nurses can use to support that. I think that we can't definitively say, I don't have evidence to say what would or wouldn't make a difference, but I think given as the evidence has accumulated, even since we started this, more and more about the clear benefits of exercise, and just what we know about behavior change to sustain exercise, that an appropriate thing to do if you're implementing a fall prevention program would be to continue to include exercise and or referrals to physiotherapy for people who need the more specialized, who can't go directly to a community-based program, which was a large portion of our people, but that more strategies to have more monitoring and support continuing that exercise behavior might be what I think might be worth putting effort into trying to support that. So that's.
Yeah, that's very clear. Thank you. I mean, yeah, I absolutely, support the idea of sort of using the community resources and having that, kind of triage approach in terms of which people actually, need, more specialised input from a physiotherapist. So,
right.
Excellent.
Yeah.
Thanks.
You're welcome.
Okay, thanks, Kathy. So we'll now ask Professor Naganathan to comment and ask questions. So Professor Vasi Naganathan is a Professor of Geriatric Medicine at the Centre for Education and Research on Ageing within the Faculty of Medicine and Health at the University of Sydney, and he's also Deputy Head of the Concord Clinical School. Professor Naganathan is also a consultant geriatrician at Concord Hospital. So Vasi, do you have any questions?
Yep, thank you, Nancy. It's we don't often get to hear from one of the investigators of a trial like this, so it's lots of fun. I suppose a comment, I think we'd all agree that on the rationale for the study, which was that one of the gaps is that there isn't data on falls injury as an outcome, and the idea of incorporating it, the intervention into real world practice. So I think the rationale for the study is very strong, and the method of collecting outcome data sort of sets the standard for future falls trials. I wondered if you could put up, because my question relates to this, if you could put up the intervention fidelity slide again.
Yeah,
that's the table 2.
Yep. Oops. Uh-oh. Sorry.
So I should have warned you.
Don't want to leave the meeting. I'm sorry.
That's all right. I can try sharing my screen. Oh, it won't let me. I can remember what's on it anyway.
I'm so sorry. Here,
that's all right. So my question on, and you highlighted this on the table 2.
Oh, I'm getting it.
Yep.
It just seems to go to sleep. Oh, whoops. There. Oh, okay. I'll get to it. I promise you. You start talking and I'll get to it.
Yep. So when you actually, it's coming up there.
Yeah. Here it comes. Yep. Oh, there it is.
Yep. So so I'll try this. If you took like those things almost as individual studies, right? So
right.
let's look at, as you pointed out, let's look at medications.
Right.
So as you said, a low proportion perhaps were identified with medications of concern, but maybe that was about what you'd expect from that population. But then of that, only 50% agreed to have people look at their medications, if you like, and maybe that's
Right.
what you'd expect. I'll leave the
Right.
exercise for the moment. The
Sure.
postural hypertension was low in terms of a risk factor, and again, that's what you'd expect. The one on osteoporosis, if this was an osteoporosis trial, you
Right.
wouldn't have, with a rate of hip fracture, I think of about 1.4%, you wouldn't have expected, even if it was, say, the zoledronic acid trial, the big bisphosphonate trial, it wouldn't have been expected to find a clinically significant difference because it's a low risk group. If you look at vision, well, the evidence is less clear. You know, there've been negative
Right.
trials and positive trials.
Right.
Home hazard, again, the rate was low.
Right.
So if you put it all together, it probably then hinges on the
Mhm.
exercise being the key thing. And
It
then,
probably does.
and then you've talked about then the question about the exercise, and then the exercise, if you put in the other trials, then comes out to, you know, the dilemma we've had when you put it all together, which is that you want to have an exercise intervention that's practical and can be done in real world. But other people, when you've tried to do it by the outsource method, which is outsource it to existing services, there've been other negative trials. And so I think that's a real, as you pointed out, I think that's a real dilemma, right?
It's a real dilemma.
The rationale for why you want to outsource it is clear because it's
Right.
more real world.
It's more real world, right?
But it seems that that's a risk that it may not be effective in trials.
Right.
So
Maybe.
it's hard to know how to get around that dilemma.
I mean, a few potential strategies could be to have more frequent, to recognize that who the fall care manager, whoever that person might be, maybe that person should be a physiotherapist, would be something that maybe if the exercise is the predominant thing, but whoever that is, maybe we just have to recognize that more contact is needed. That the concept of this was that the fall care manager was identifying and referring on to other services. And so then checking in when problems arose, or checking in, they saw them 6 monthly, then annually. So they weren't meant to be the major deliverer of, say, the exercise, although they ended up providing examples and things to them. But maybe we need somebody more centrally who provides more frequent contact. The other thing, and that I'm just starting a project that I'm involved in, where we are exploring, trying to develop some ways of in primary care, with the electronic health records, identifying people at risk, and then coming up right seamlessly within those systems of exercise recommendations, but then having an app or other way that the patient can log in and can potentially have some communication back with the primary care doctor about how their exercise is going over time, or how they are or are not, to sort of have a feedback loop, so that a person doesn't go from their annual assessment a long period of time before they check in again to say what happened with that community program. So those are just a few thoughts.
Yeah, thank you.
But yes, I do think, and the other thing that, of course, now, when you have a study where it's positive, you just think, oh, we did it all right. And then when you have one that has the primary outcome is a null effect, of course, you critique everything deeply. But of course, I think there's a lot of reflection on, we went with the evidence at the time, but maybe in a next version, it would make sense to not have 7 factors. Maybe we should focus on just the ones that we think are the most potent ones to change, which of course exercise would be in there. And then is there some, I mean, the addressing osteoporosis seems important too, but just trying to figure out maybe a smaller pool, but more intensively targeting those.
Okay, well, thank you, Vasi. So we'll now hear from Professor Stephen Lord. Professor Stephen Lord is a Scientia Professor at UNSW, and he's an NH and MRC Senior Principal Research Fellow. He's the Director of the Falls, Balance and Injury Research Centre at NEURA. So Stephen.
Thanks, Anne, and thanks, Nancy. I'd also like to say it's just wonderful to see the results of this trial, such a huge endeavour. A major effort for fall prevention. My first question really is, can you tell us when this was conceived and planned, just to give us an idea of how big it was?
Right, of course. So it began in, it was actually in 2013 that the PCORI, which is a fairly new research funding agency in the US that focuses on patient issues, patient-centered issues, and also involves a lot of patients and stakeholders in their studies, decided this was a priority area, but also decided that they would partner with the NIA. It was the first time that they had done this, I think, because it was such a large study and the NIA has expertise in this. So they issued a request for applications at that time. And so we began the actual work. Our team was awarded it and began the work on it in 2014. The work on the actual study began. And we had sort of a pilot year to work together and work out the data management and all the different systems and protocols, and the actual main study started then in 2015.
Yep. That's a major undertaking and clearly a big part of your life.
Yes, it's part of my life.
I've got just a couple of methodological questions just to get a feel for how the intervention actually took place. One's about the assessment. So did the participants come into a study centre? And were all of the risk factors measured objectively? For example, vision, was that measured directly with a vision chart, and postural hypertension with a 3-minute test and somewhat? And the home assessment, did that involve the nurse going to the person's home to actually do a check of the home?
Right, so those are great questions. So the patients came into their primary care practice to receive the intervention. As the study evolved, went on, a small number of the nurses would occasionally go and see the people in their home for follow-ups, but this was essentially designed to be to take place in the primary care practice. As part of the assessment was about an hour long that the fall care managers had with the patients. They directly measured postural hypotension, lying to sitting with the blood pressure. If they had a recent vision assessment, they did not recheck it, but if they did not have on record a very recent visual assessment, they did check their visual acuity. They conducted, they used the short physical performance battery to look at their straight gait and balance, and that was also used to help triage people into the whether they would need the type of physiotherapy they might need, or if they were able to go to a community-based or home-based program. For the home assessment, that was one that was not done with an actual visit to the visit replicated what you would have in a physical assessment. For the home assessment, they asked people questions about their home and they gave them a checklist that they could take home and complete for that, but we did not. And then as part of our algorithms, especially if people were people who would particularly indicate a need for home safety hazards. So especially if they had a high fall risk and had visual problems, then an occupational therapist might come to their home. That's fairly difficult to obtain in the health system. So that was a relatively, not that many people fell into that category and received that, but that was part of the algorithm. But the fall care manager themselves did not go and conduct a home safety evaluation.
And I have two more questions. Am I allowed to keep going? Okay. There's another one. The other wonderful thing about this trial was the piloting. So you piloted what you thought might be the fall rates. You piloted the interventions to see if people would take them up. And what happened in the pilots didn't really happen to the same extent in the actual trial. So the uptake was a little bit less, and the fall rate in the controls was lower than expected. So
yes,
that affected things. And can you comment on, why would that have happened?
Well, I am not sure why that would have happened, but I do think that I think potentially for the control, I think for the control fall rate, it just might be that as much as we were trying extremely hard to make it a pragmatic trial, we had very few exclusion criteria. I think maybe people still had to consent to participate, and maybe you just still have a slightly healthier, slightly less at-risk population when you actually are implementing a study than we were initially in the pilot, where maybe we were just able to get and in observational data that we were relying on. I just think that we tried very hard to make it pragmatic, but I still think you never get an exactly representative population that agrees to be in a trial. So I think that slightly healthier or less risky population could just mean we had a bit of a lower fall rate potentially. I think for the uptake, I think again, we were, I think when you're doing a pilot, you sometimes are getting the people who are very excited and enthusiastic and willing to participate right away. And these were, again, we were getting to a more realistic population really, who their uptake is just when you're taking basically every older people, even the ones with severe cognitive impairment, even the ones who have a whole range of other health problems. I think that it was just, and trying to get them to come into the practice and participate and make these changes, I think it just is reflecting the reality of what people might do in a more realistic situation. So.
Okay, yeah. I guess my last one, it's a bit like Fuzzy's question, and it goes back to the debate many years ago in JAGS about, do you do multifactorial interventions, or do you do one thing and do it well?
I know.
And so this is the Campbell-Robertson argument about maybe we should just do exercise.
Right.
And make sure it's undertaken well, and we might get just a big effect if we really implement one thing. Would you comment on that at this point?
Well, I am a physiotherapist, so I do think that there is strong and growing evidence that exercise is clearly the most effective single intervention. And we did, you can see when you look at that was our fall care managers also understood that, and they were excellent practitioners, I have to say, and they really encouraged people to to take up exercise and to teach them the importance of that. But I think that, I guess I don't have a trial that used the same approach to say what exercise alone would have done, and I think it's completely rational to be looking at the multifactorial approach. But I guess I would say is if I had a patient in front of me and limited time, I definitely would emphasize exercise most of all if that was the only thing that I thought they could only uptake one thing. So I think that I think that we still can't be sure if it would have been better to only focus on one. I mean, even though we had a small number of people with postural hypotension, that alone can be making people fall no matter how much they exercise. But I do think that clearly, I think it is worth continuing to focus on exercise and then also continuing to try to think about how can we support people sustaining that exercise long-term in the community? So different innovative strategies.
Thank you.
Okay, so we're starting to run out of time. So I'm going to just ask some of the audience questions now. So the first one is, the control group got enhanced usual care. Do you have data on the level of falls intervention activities in the control group?
No, so we don't know. We don't know what sort of if they, for example, started community-based exercise or things. But it is definitely true, and perhaps that had a tiny effect on the fall rate in the control group too. I mean, both their primary care doctor and the patient were informed that they were at risk. And were given information about fall risk and encouraged to talk to one another. So that alone might have changed some things that could have diminished the difference between the two groups slightly. Although if just that works, that would be a little bit surprising if just that has a huge treatment effect.
Yeah, exactly. And I also wondered, you said that the physicians had the chance to undertake education through a webinar. Did you record what proportion of the control physicians took part in that education?
I honestly don't know if we have that data. That's a good question. We can look back. I honestly don't know that.
The next audience question is, were the falls care managers new to those practices, or were they recruited from existing practice staff?
That's a good question, and it was a combination. I think about, I would say, I think it was about 50-50 that they were part of that health system. I'm sorry, another thing to make clear is about half of them were part of the health system, but they were moving around different practices within the health system. So all of them would have been new to at least the majority of the practices. So they were in a different, it was a role we had created, and they were moving around different practices. And some of the fall care managers were new to the health system, brought in strictly for that role. We had quite strict criteria about the background they needed to have. But I think that is a really good point, that as much as we tried to make it pragmatic, in some ways there definitely was a curve, especially even for ones who are part of the health system, to fully integrate with the different primary care docs, which in a completely real world situation, if they were all people who had been there all along, that might have been a shorter sort of time. So yeah, I think there was some variation in that.
Another question, was a process evaluation undertaken as part of the trial?
So we did not, as the trial was ongoing, we did not complete it as the trial was ongoing. We did do a separate small sub-study, which we're writing up right now, where we conducted focus group with a person who is not part of the study, with the different members of the study team, to explore from all the different perspectives of the fall care managers, the some of the primary care docs and leaders of the health systems and other study members about what they saw as the barriers, facilitators throughout the study, what had and hadn't worked in the study. And so that is a publication that is under review right now.
Right. That'll be really interesting to read.
Yes, yes, yeah. There's really interesting things there. So.
Another question, out of the 8% of participants who passed away during the trial, is there any data of the cause of death? Were any of those deaths fall related?
Yes, but there was no difference in the fall related deaths between the two groups. And in our overall safety evaluation found overall no difference in hospitalizations for any cause, overall no difference for deaths of any cause. And they were all MEDRA coded. So we looked at the causes of death and no difference in fall related deaths. I don't know the exact number off the top of my head, but there definitely were fall related deaths.
Okay. I think this might be the final question. So someone's asking the difference between the primary and secondary outcome. Was the primary medically confirmed, but the secondary self-report? And if so, could the falls and injuries have been treated by organisations outside of the primary care practice in which the participant was enrolled?
Yes, for both the primary or the secondary outcomes, the injuries could have been treated outside the primary care practice. If they reported an injury that was the treatment, we were not able to obtain the medical records from the primary care practice, we wrote to try to obtain the medical records from the other providers. And because we were also able to obtain the Medicare data records for most people, we had another way of also confirming that no matter where the person received that treatment, as long as it was within the US. But there certainly were some people for our primary outcome that, because if it took place in another country or it took place that we simply, we know there's probably a small number that we weren't able to get that confirmatory other record to confirm the self-report because the data, for whatever reason, simply wasn't there. So there are a small number of those. Whereas the secondary outcome, it was simply the patient's self-report of their injury, whether it was minor or not, and we did not go to all that work to confirm it with a secondary source and adjudicate it.
Okay. All right, well, it looks like we've run out of time, but I'd really like to thank you, Nancy, for a fantastic session. It's been really interesting and thought-provoking. And there were a few extra questions on the Q&A that we might ask you to answer, and we can put them out there with the recording of the webinar.
Oh, yeah, I'd be happy to. Yeah, that's great.
So yeah, again, thanks a lot, and thank you everyone for joining us. It was a really great discussion, and it's a fantastic achievement getting that trial done. I don't know whether the panelists would like to say anything else. Kathy?
That's okay. Yes, yeah, again, congratulations, and yeah, thanks everyone for your interest in the topic.
Okay, so stay safe everyone. Bye for now.
Thank you. Pleasure.
Thank you. Bye-bye.
Bye-bye.